DTAC. I'm going to do a quick roll call. I'm Charles Macias. Deb Brown is not here. Britt DeVillier, not here. Bonnie Hartstein, not here. Charles Jaquith, not here. Juan Juarez, here. Julie Lewis, not here. Jorge Sainz, here. Sally Snow, here. And Vern Walker. I suspect, and I don't know how much impact this weather is going to have on the rest of the meeting, but I suspect much was influenced by that, since we did know that many of these people had intended to attend. That also means we don't have a quorum, so we will go through the discussions of some of the elements, but since we can't vote or decide on the initiatives that we had intended for two very large agenda items, one is the National Readiness Project, and the other is the minimizing radiation. Those will be simply informative, so I imagine that will be done probably in half an hour or so. All right, so we have only 3 committee liaison reports. Air Medical, Jorge Sainz.
From the last Air Medical, there was no specific pediatric issues discussed, and today we're actually going to have a meeting following not this meeting, but after that meeting, so I'll send you the report.
Okay. Next one is medical directors. Juan Juarez.
Medical directors met yesterday. No real specific pediatric issues that came up, but there were some big issues that just FYIs for us to know about. Recent EMS committee meetings around the state where they passed 2 pieces of legislation. They're going to get approval through GTAC on Monday for their fraud in ambulance industry piece.
And what does that encompass?
That encompasses 5 key areas. The first, increase education and accountability of EMS and proper use of ambulance service to patients. 2, to increase process of regulatory people for EMS, to know the regulations and enforce current regulations, to increase personnel. So relatively more enforcement of the current legislation out there. 3, they wanted to keep one type of licensure for the ambulance service, to not split emergent and non-emergent ambulances. 4, there are a few updates and refinements to the proposal of the current legislation, specifically, I think, a jurisdictional approval of licenses for ambulance services. And 5, to increase requirements of legitimate practices, to show proof of business facilities, et cetera, to show proof of ownership of equipment that are leased, and developing a 5-year plan for all EMS services to be on an EMR. So these 5 areas are inclusive within that proposal going forward to GTAC.
Is there any link with equipment and what we've talked about of recommended pediatric equipment?
Not in this. They also had a report by the Stroke Committee to discuss CME hours for EMS. Want to require 4 hours that will last for 4 years. Proposal to make a policy at the state level. Possibly a pediatric component there, but they haven't reached out to it as of yet. They also discussed their position statement on mental health care and EMS and emergency care. They took comments during the last meeting, and so they wanted to propose to work with local and regional mental health inpatient facilities to create a standard definition of medical stability, which limited the previous scope of their position before. Basically a rewording of what they wanted to propose so they can take to GTAC. Work with professional associations representing inpatient psych facilities to get acceptance of medical stability. Determine if there are medically stable patients whom EMS personnel could transport directly to inpatient facilities, inpatient psych facilities, or other non-ED facilities like sobering centers, crisis centers. And then lastly, work with professional organizations representing law enforcement agencies to draft legislation authorizing emergency detention of patients at risk of harming themselves or others by non-law enforcement personnel. So they've been reworking their position to get the wording just right, and they're able to take that forward as of this meeting.
So I think it's challenging, especially for those of us that work in the emergent care settings, as challenging as it is to deal with mental health in our healthcare systems. It becomes even more challenging with the pediatric mental health issues. Is there any area there that specifically addresses facilities that
Not
are ready?
specifically to pediatrics at this point. And
Is
lastly-
there opportunity?
There is, as with the other pieces, I think as they take it forward, they have their representatives on their committee that we can reach out to and address specifics should we need to. The last issue, there was a possible endorsement of the NAEMSP and ACS positions on longboard use by EMS. They're taking that to GTAC to disseminate to the state. This has to do with clinical field clearance from the backboard, which they've been doing for years. This just kind of solidifies the process. With some of these other positions, they also wanted to make sure that for those services that didn't have medical directors, that they create not only the position statement, but create protocols that would help guide some of these services to become more standard with the rest of the state. And so they were going to go forward with that.
Is there an age range targeted for this longboard position statement?
They didn't specify an age, but it's going to be looked into a little bit more deeper by Dave Spears. He'll take that on, and I'll reach out to him specifically because there's some issues in terms of car seats and those types of things.
Right.
So I'll reach out to him.
Okay. We have trauma systems. Sally?
I reported last time on the August meeting, and today is when the meeting is this afternoon at 4.
Okay. All right. So that takes us through liaison reports for the people present. The other reports are from people not here. Next agenda item is update on child fatality review team's update. We actually presented that at our last meeting. Susan Rodriguez could not be here for this meeting, so that takes us to position paper on minimizing radiation. Jane was very nice in helping us arrange for Jerry Cogburn from Radiation for the State. Jerry, we'd love it if you'd be able to help us navigate through the issues of what the state offers. Just for members of the public, we had issued a position paper that was supported by large GTAC, looking at the planks that are on your agenda items, but specifically encouraging minimization of radiation. This is especially important in children, as their growing bodies are much more susceptible to the effects of radiation. Some data suggest, both cross-sectional observational studies and some correlational studies suggest that there are about 500 cancer deaths in children from every 600,000 CTs, and so that's why this has become a burning issue for us.
Well, you had asked about pediatric-specific information, and really we don't have any in radiation control. We don't parse the rules that way. We just have an effort to eliminate any unnecessary exposure to radiation. So any human exposure for a non-medical purpose is prohibited in our regulations and the Act. So I don't have anything related to pediatrics specifically. I can show you that on our website we are linking to the Image Gently campaign. That is a resource for our registrants in order that helps them meet our current regulations. The last time I talked with you, we were either just ready to roll out the latest revision of the radiation control rules, or maybe they had just come out, I'm not sure. But in those rules, we had made some specific changes that we hope will result in reducing radiation exposure overall, and especially some of those accidents or incidents that occurred like those at Cedars-Sinai where the children got highly excessive exposures. One of the major new parts of the rule establishes the requirement for a facility registered with us to use radiation machines to establish a radiation protocol committee. And they have to establish this committee if they have CT or they perform procedures that we've defined as fluoroscopically guided interventional procedures. The committee has to have a minimum membership that includes a physician, the radiation safety officer, a licensed medical physicist, and anybody else that the facility deems necessary. They are required to meet at least every 14 months. Meetings, the minutes are there are minutes kept for each meeting. Those minutes are preserved for inspection by agency inspectors. That we will take a look at those at every routine inspection of that facility. The purpose of the committee is to develop several things. First is written protocols for conducting all fluoroscopically guided interventional procedures and all CT procedures. They also must establish what we're defining as reference levels for these procedures.
So do those recommendations, are those recommendations specifically that, or is it left up to those committees to decide what those recommendations must look like?
Recommendations
Do
for
those
what?
come for you? So let me give you an example of where we're going with this. Is there opportunity for pediatric dose reduction protocols?
Yes. That's the objective of the committee, is to establish written protocols for all CT procedures, which would include right-sizing the dose for pediatrics.
And is there a standard of which they are guidance from a state or national level that they are to use as reference?
We don't have any national standards established. There's, nobody knows exactly what will be a safe level of radiation. That's why we just try to limit all unnecessary radiation.
And I understand that. So how do you standardize? Let's just say there's 150 groups that are established committees,
Mm-hmm.
and 150 different protocols. How do you standardize those folks?
They will not be standardized.
Is there opportunity to recommend that they access pediatric protocols from the Alliance for Radiation Safety for Pediatrics?
Not in the regulations. We did not include that in the regulations, that they have to go by whatever the Alliance recommends. No. This is sort of a first step in the regulations. We did initially, when the rules were being promulgated, we did at one point have some recommendations in there for dose limits, and we got a lot of pushback from everywhere. So we pulled back on that, at least for this step. The protocol committees will have personnel on them that will understand the machines that they're going to be using at each location, and they should have the capability of establishing a reasonably safe exposure level.
So I think the concern is that we worry less about pediatric facilities that see 80,000 children through emergency departments and have specialized radiologists. Likely those kinds of committees are going to be attentive to the needs of children. I think we'd be more worried about community hospitals that may see only 1 to 2% of their population and by process don't have pediatric specific CT protocols.
That remains a concern. We don't have that solidly addressed in the rule. We hope that the the attention that these latest events have attained have impressed on the physicists and the physicians the importance of adjusting their protocols for pediatrics when they see them come in.
So I think back to sort of the overall genre of how innovation in science gets uptaken, and most research takes 13 to 17 years to get uptake. And my concern is if we leave that passive uptake, it may be 15 years before we see the issue addressed, when 90% of pediatric emergencies are seen in community-based hospitals. So I guess what I'm really looking for, and I think what this group is looking for, is where's the opportunity to accelerate that? When are the rules open for revision?
We're required, or it's recommended that we open the rules for revision every 4 years. So that'll be 2017.
Okay.
And based on your current structure, did you model yourself after any other states and their processes, or is this something we're starting from scratch?
We always poll the other states, find out what they're doing specifically, but in this case, I think California was the only one that was doing something rather aggressively, and that was probably because Cedars-Sinai is in California. They enacted some rules that were I'm not very familiar with, but they went further than we did for sure.
And are your limitations in your radiation, do they take into account the kind of current FDA recommendations on new equipment with pediatric-based dosing pre-implemented, or is this taking into account older generation equipment?
I'm sorry, I didn't hear all of that.
So as of, I think, about 08, 09, that time frame, the FDA took a stance on kind of this minimizing radiation stance. So they implemented across the board all new equipment to have standard pediatric protocols built in and things like that.
Yes.
So these committees take into account those recommendations for the new equipment, or?
Well, we hope so, but we didn't. That's not in the rule. We gave, each facility has different capabilities, different equipment, sure. And so it was important to let the protocol committees deal with what they had available. And so it's just not there.
Yeah.
No.
So I definitely think this is a good start, and the attention to the potential harm from excessive radiation. I think this kind of work will really help bring that to light. So I'm hearing two opportunities. One, to revise the rules in 2017. Of course, that's quite a while from now. And the second, and I'm not sure if I read this correctly, but you mentioned that you link to Image Gently. Is that correct?
On the website.
On the
on
website.
The radiation control website. Yes.
So if this group were to not only offer posting of our position paper, but offer related pediatric websites for minimizing pediatric radiation, more information on that, which we've accumulated quite a few, is that something that could be linked to this website?
I'm sure it could. I don't have authority over that, but I'm sure
Who
that they
does
wouldn't have any trouble doing that. Yeah.
Okay.
And regarding your input on the regulations, you can submit your recommendations at any time. All recommendations come into us all the time, and we file them and keep them for the next round of revisions. So at any time this committee wanted to make a recommendation, they can submit it to radiation control. Right now, it's Policy, Quality, and Standards, PSQA.
Okay, I think that's great to know. Since we don't have a quorum, we can't vote on what the content of that is. But if we had somebody to volunteer to piece that together, or to work with me to piece that together? Okay.
Can I ask a question? Is there anything in the rule that requires hospitals to monitor cumulative radiation on a patient-by-patient basis?
That was another thing that started out in the rule, and there was a deafening pushback on that. Right now, they are required to establish these reference levels. So, and the purpose is to have a tripping point when they can, one, follow up with the patient to make sure they don't have any indications of radiation effects. And secondly, as an indication that they need to review their protocols.
So it's a recommendation, not a rule, not a requirement?
It's in rule that they have to establish the reference level and procedures for follow-up and reevaluating their reference levels.
Okay, thank you.
All right, thank you so much. That was very helpful. All right, so that means we cannot come to resolution on next steps for all the items that followed that, which takes us to number 4, EMS for Children State Partnership Update. Sam Vance.
Click on view response rates. Good morning. My name's Sam Vance. I'm the EMS for Children Program Manager. I just wanted to give you all an update on the EMS reassessment. As of today, we're a little more than halfway through our cohort, which ends on January the 8th. And as you can see by the map up there, we are at a 45.4% response rate right now. Excuse me. And just to give you a reminder, the assessment is being done as a random sample survey of all of our departments throughout the state. That includes all of our ambulance services, our fire-based EMS, and our first responder organizations. And the first responder organizations were included because, as y'all know, they do respond to the pediatric emergency medical calls, just as they do with all the adult calls, and they can be on the scene for several minutes prior to the ambulance's arrival. So it's just as important to find out what their capabilities are of taking care of children as our ambulance services. But as I said, it is a random sample survey, so all those organizations' names were put into the computer at the National EMSC Data Analysis Resource Center in Salt Lake City, Utah. And the computer randomly picked out the names of the departments to participate. However, if there are departments that would like to participate in the assessment, they're more than welcome to. They can fill out a hard copy of the assessment, and we will enter their data at the end of the cohort.
Can I ask you a question about that,
Yes,
Sam?
ma'am.
Will that go towards our requirement, or will those be extra over and above the ones that were picked out by NEDARC?
Those, the way I'm being told right now, those will be extra.
Okay.
That will go above and beyond what NEDARC requires. But from what I'm also being told, there may be some wiggle room with that. So they're not 100% sure yet. They want to make sure they just get to the end of everything, and then they'll make that final determination.
Because I think the bigger issue for NEDARC is that they're really trying to do sampling windows
Right.
with good precision, so this helps even if it isn't what was originally intended.
Right, and one of the suggestions by NEDARC was that we do our sampling, and then this other group, we could make just a separate sample from.
And we talked about setting up a computer in the exhibit hall and letting people fill out their surveys while they're here at the conference. Is that happening?
Yes, so we do have hard copies available, and we will have computer available, that if those department representatives who have not completed the assessment are here and would like to do it while they are here, we are set up in booth 509. So stop by and visit us, and they can fill that out while they're here. Lastly, I'd like to thank those departments who have completed the assessment, as well as the RAC chairs and directors who have helped contact those departments, and the folks at DSHS here for helping me out. So, are there any other questions?
Opportunities for us to help contact people?
Yes, so, excuse me, we have sent out emails and letters to all the participating departments. We've also started making phone calls. I have sent out, I believe that was the day before yesterday, I sent out the list to our advisory committee, but I can also send the list to the pediatric committee as well as those departments that are participating by RAC.
Okay, I think that would be helpful, especially for, we purposely construct this committee to have good geographic distribution, so hopefully there'll be a good match there for.
Okay. Yeah, so the list that I'm currently have, it's a working list, so the list I will send are the ones who have not filled out the assessment yet.
And remind me, how many are on that list that have not filled out the assessment yet?
Well, let's see. Starla, could you hover the mouse over the state there? If you could take the mouse and just hover it over the state. Okay, so we had 217 respond out of 478. So what is that, 261, something like that? I don't do math.
Okay, and that deadline?
January 8th.
Thank you. I know I heard it and I
All right.
didn't type it.
Any other questions?
That's it.
I'd like to also recommend, oh,
Thank you.
All right, thank you, and I was going to bring that up at the RAC chairs meeting, so, but thanks. Yes, I will send that out to the chairs and directors as well.
and I was going to say that something similar. If there are people in the audience that are the pediatric champions in their RACs, if you have not heard from your RAC chair or executive director to help with this, please go to them and say, can you give me the list of people in our RAC that have or have not completed the assessment? Because I know in Trauma Service Area E, we have zone representatives for 8 different zones of our 19-county area, and those zone representatives are real good to help us with getting people to participate. So.
Sure. I do know that a lot of the first responder organizations don't necessarily participate in the RACs, if that's correct. And those are some of the ones that we're having a little harder time getting a hold of. And to be quite honest, some of those first responder organizations don't feel that they are part of EMS, even though they are. And like I said, it's just as important that they have the capabilities to take care of kids as everybody else. So.
We can help with that on a RAC level, I think.
Okay, thank you. Anybody else? All right, thank you.
Oh, Sam, did you have
Yes.
any update on NPRP, specifically on the quality improvement piece?
I do not, but I can say that we do have all of our state data now, and we have been able to do an initial analysis of the state data and have been able to break it down by region. 2 weeks ago, I did attend a NEDARC workshop in San Antonio that would help us analyze the data a little further, and we are breaking things down that way. I believe that Dr. Shaw plans on presenting a little more detailed report to the committee in February.
Okay.
Now, and I have been to a couple of the different RAC meetings to present their regional data, just as an initial type of report.
Okay, I think for the purposes of posting documents, I assume for the February meeting, Jane, that deadline is in December or early. Does that sound about right? First week or two of January. So is it possible that we can get those reports and maps? Because I think we'd love to be able to have some public discussion of those.
Sure. I'll talk to Dr. Shaw. Like I said, I know that he's been working on it as far as trying to put together a detailed map of all the regions in the state.
Okay,
So.
great. Thank you so much.
All righty. Thank you.
All right. Item number 5, our own review of National Readiness Project activity and what we will, and coming to resolution for strategies we would take. Without a quorum, we can't make any decisions about that. So I'll skip to number 6, which is pediatric transfer guidelines. Review Washington State pediatric consultation.
The only thing I had to talk about there, and it probably is something that would require a quorum to make a decision on as well, was I didn't, and I could be old and don't remember, get clear direction on what it was we wanted to do with this. I presented the Washington guideline at the August meeting, and my vision is that we would put together a task force to actually begin to build a transfer guideline for the state of Texas based on many other states that have those, and try to move them forward. Juan and I talked earlier, and we think that we're going to need a fairly broad work group to try to get this done and to be able to get people to buy into it. So.
And do you envision this task force to be within this organization, then reaching out, or is it within this subcommittee with members of other subcommittees?
That's what I think we need. I think we need, medical directors and EMS, well, yeah, EMS for sure, lots of input from other subcommittees of GTAC.
Jane, can we, a procedural thing, without a quorum, can we establish a task force at this meeting, or must it wait to the next meeting with a quorum? Okay. We could just establish that now and ask forgiveness later? Okay. So why don't we move forward with that? Sally, would you be willing to chair that and give us some guidance for what that needs to look like and who the members would be specifically at our next meeting? And then hopefully just a rough set of goals and objectives.
Okay.
And what the deliverable needs to look like.
Okay, do you want me to approach anyone about serving on the task force, or just kind of define who the players would be and the goals and objectives?
I think we clearly need EMS and medical directors. Would you agree with that?
Yes, absolutely.
So why don't we start with that and then move forward with additional members after that has been established and discussion has been initiated?
Transfer guidance, interfacility transfer.
Yes.
Yes.
So maybe a medical also.
Oh, yeah.
There you go.
Yes, ma'am.
RAC representatives. Anybody else?
Chat.
Chat. Okay.
Okay.
All right,
awesome.
there'll be another opportunity to add additional members. Okay, great. Trauma registry report, and I think this is our last item. Yep.
Yep, on that other item that we're just finishing, Charles, the National Pediatric Readiness Program, they has a couple of well-developed toolkits for interfacility transfer already, which are actually, I found, quite useful as far as, how to set up basically memorandum of understanding between transfers, facilities and all the other personnel and some criteria. So some of the groundwork, has already been done.
Absolutely. I was on the committee that developed that toolkit, so I'm very familiar with that. That's a great place to start. And it includes the Washington State guidelines, and who else did you tell me had a good one? Minnesota. So, we'll look at all those.
Okay, great.
All right. On the other specific item as far as the trauma register, we had been meeting pretty much every month. There was a meeting that took place at the beginning of October, actually in Austin, where I couldn't attend, but I actually was able to link through phone. And basically, and Jane, correct me if I say anything that is not right, but over the last 3 or 4 meetings, there's been a lot of discussion to see, how EMS, the register part of EMS is going to be linking with the hospital setting EMS, system, and there's been a lot of discussion as how to create a symbiotic relationship of entering data in one site and being able to populate that data on the hospital component. We're actually going to be meeting tomorrow at 10:30 in order to continue with those discussions. from the pediatric standpoint, we had recommended to assimilate, some of those components that will include child abuse and to be able to recognize child
Submersion.
abuse. Huh?
Submersion injuries?
Submersion also. But, so we're going to continue to talk and advocate, for that regard. Anything else, Jane, you would like to add?
The what?
The link
Between
between
EMS and
EMS and hospital.
EMS giving hospitals back information. Or hospitals giving EMS back information.
So the hope is that we create a symbiotic, platform where, those two settings are going to be able to interchange rapidly and effectively data in order to provide better care in the future. Mm-hmm. One of the things that we keep saying is that the trauma register, if it's going to be done right, eventually will save lives. And that's the whole goal about doing this data compilation, for the state.
Okay, thank you. So that takes us to open general public comment. That's all our agenda items that we're able to do without a quorum today. Any general public comment? Jane, any other issues? All right, well then our next meeting's in February. This meeting's adjourned. Thank you.